Today, Hannah, Lisa, and Winnie are going to present on polycystic ovarian syndrome. This is important for sonographers as it is often misdiagnosed due to constantly changing criteria.
Polycystic ovarian syndrome is a complex endocrine disorder caused by a hormonal imbalance that interferes with normal ovulation. Polycystic means many cysts. In women with polycystic ovaries, often 15 to 30 eggs per ovary are growing at once. None of them fully mature for ovulation, and instead they eventually form small cysts. The pituitary gland in your brain makes luteinizing hormone and follicle stimulating hormone. After getting the signal from the hormones LH and FSH, the ovaries make estrogen and progesterone, the female sex hormones. All normal ovaries also make a little bit of the androgen testosterone, a male sex hormone. The pancreas is an organ that makes insulin. High levels of insulin can also cause the ovaries to make more of the hormone testosterone. PCOS happens when a hormone called luteinizing hormone from the pituitary gland or levels of insulin from the pancreas are too high, which then causes the ovaries to make extra amounts of testosterone. Although the exact etiology is unknown, PCOS is a multifactorial disease with a family history of the syndrome quite common, as well as environmental factors to determine the phenotype. Risk factors of PCOS include obesity, which causes hormonal imbalance and menstrual disturbances, a lifestyle with less exercise and unhealthy eating habits, a family history of PCOS and genetics. PCOS is more likely to develop in women aged 15 to 30. Signs and symptoms of PCOS include weight gain, extreme tiredness, unwanted hair growth, thinning hair on the head, infertility or trouble falling pregnant, acne, mood changes, pelvic pain, headaches and migraines, and sleep problems like sleep apnea. Diagnosis for PCOS includes blood tests to determine the levels of androgen and glucose. This can rule out other issues as well. A family history should be taken to assess the risk of developing cardiovascular disease and diabetes. This is important when testing for PCOS because there are links between PCOS and insulin resistance and being overweight. Pelvic ultrasound can be used to assist in PCOS diagnosis. In some cases, there can be polycystic ovaries on ultrasound to prove PCOS, but in other cases, there is no sign of polycystic ovaries, but there are other signs and symptoms of the syndrome, such as hyperandrogenism and amenorrhea. The Rotterdam criteria is widely used to diagnose PCOS. The four phenotypes are Type A, polycystic ovaries on ultrasound, high androgen levels, and irregular menstrual cycles. Type B, polycystic ovaries on ultrasound and irregular menstrual cycles. Type C, high androgen levels and irregular menstrual cycles. Type D, high androgen levels and polycystic ovaries on ultrasound. In 2003, the Rotterdam criteria was the first to bring in the role of ultrasound of the ovaries as a diagnostic criteria. The goal of imaging in PCOS is to identify polycystic ovaries. Transvaginal ultrasound is preferred for imaging as it will give the best view of the internal structure of the ovary, especially in larger patients. Transabdominal ultrasound is generally used in adolescents or women who have never been sexually active, or women who refuse a transvaginal ultrasound. Since PCOS is by definition a syndrome, the presence of polycystic ovaries alone is not enough for diagnosis. Before we begin the ultrasound scan, it is important to take a thorough patient history, asking the patient for their clinical symptoms, how long they've had them for, and the severity of it. Note that some patients who have previously been diagnosed with polycystic ovarian syndrome expect to have large multiple cysts because of the name of the disease. However, as we only consider cysts to be follicles that are larger than 3 centimeters, be sure to understand the patient when they describe they've had cysts before, as it may not actually be correct. As PCOS is hormone related, finding out if the patient is currently taking any medications, vitamins or supplements, and the doses they're taking is important. Recent life changes and stresses can also affect the hormone cycles in the patient. Other questions may include when their last menstrual cycle was, the frequency of it, or whether they've noticed any weight changes since menarche. When scanning for PCOS, we often use both the transabdominal and transvaginal approach as they provide different information diagnostically. The transabdominal approach allows us to visualize a wider field of view so we can check for other pelvic masses or abnormalities in surrounding tissues outside the uterus. The transvaginal approach is an optimal sonographic technique as it provides the best detail anatomically, although it is limited to a smaller field of view. Taking the measurements for the ovaries in a transvaginal scan provides better accuracy than a transabdominal scan. Note that prior to beginning the procedure, it is important to obtain written consent from the patient as a transvaginal examination is considered to be an invasive procedure. When conducting the scan for PCOS, pay particular attention to the ovaries and note the size, shape, and echotexture and whether there are any solid or cystic lesions inside. If there are more than 12 follicles present that are under 9 millimeters in diameter, take a note of this, as this could be an indicator of PCOS. Note that there are recent discussions of the Rotterdam criteria to be modified to have a count of over 25 small follicles for PCOS. A normal ovary will appear to have an ovoid shape and can look quite flat. The size of a normal ovary will be less than 10 cc in volume and can have the presence of anechoic follicles inside. The echogenicity of the ovary will be similar or can appear to be more hyperechoic compared to a normal uterus. In a polycystic ovary, the shape will appear to be more rounded. It will also be larger in size and have a volume that is greater than 10 cc. Polycystic ovaries will have more than 12 small antral follicles between 2 to 9 millimeters in each ovary. These follicles will generally be scattered peripherally along the ovary, giving off the appearance of a string of pearls. After completing the scan, it is important that the imaging report be documented and recorded correctly for legal purposes. This report should include all the patient's details, including patient history and any findings previously spoken about prior to the scan. It should also include the number of follicles counted and ovarian volumes, as they are key indicators for assisting PCOS diagnosis. Also include additional pertinent findings such as the presence of a dominant follicle or a corpus luteum.
While the most common cause of hyperandrogenism is PCOS, other disorders must be excluded before making this diagnosis. Hyperandrogenism is also present in disorders such as ovarian hypertrichosis, androgen-secreting tumors, Cushing syndrome, and congenital hyperplasia. These disorders present like PCOS with hirsutism, alopecia, weight gain, acne, and infertility. While there is no cure, treatments are designed to manage the hormonal, metabolic, and reproductive symptoms experienced by women with PCOS. Adopting healthy lifestyle behaviors, such as maintaining a balanced diet and regular exercise, should be prioritized, as a 5 to 10% weight reduction has been shown to significantly improve symptoms and optimize hormone levels. Pharmacological treatments, such as the combined oral contraceptive pill, may be used for the management of hyperandrogenism and irregular menstrual cycles. This pill may be combined with metformin for the management of the metabolic and hormonal effects, especially in those that cannot achieve and maintain the desired goals with diet and exercise alone. Anti-androgen medications may also be considered with the pill and/or metformin to treat hirsutism and androgen-related alopecia. The reproductive effects of PCOS are managed using 3 lines of therapies. The first line involves medications with letrozole, clomiphene citrate, and metformin to induce ovulation in women with aneuploidy PCOS. If these treatments fail, gonadotropins can be used with ultrasound monitoring for ovulation induction as a second-line therapy. In vitro fertilization is a third line of therapy that can be used. PCOS is associated with numerous complications if symptoms aren't managed. Women diagnosed with PCOS may experience long-term metabolic effects, including impaired glucose tolerance, also known as prediabetes, which can develop into insulin resistance and diabetes mellitus over time. Other complications include hyperlipidemia, non-alcoholic steatohepatitis, also known as fatty liver, and an increased risk of developing cardiovascular disease and gestational diabetes. Women with PCOS may also experience reproductive complications, such as infertility and recurrent spontaneous abortions. Further to the metabolic and reproductive effects, individuals with PCOS may experience psychological complications, including moderate to severe anxiety and depression, effects on body image, and eating disorders. In conclusion, it is important that sonographers are aware of the ever-changing criteria of PCOS and are able to identify the sonographic appearances of polycystic ovaries. Note, however, it is not the only tool used to diagnose PCOS, as it is a multifactorial disease and needs to be treated on a case-by-case basis. Thank you.